introduce Robin Curnel. Robin Curnel works with our hospitals on promoting interoperability. She also is part of our Coverdell program working on improving outcomes for stroke patients. So we're excited to have Robin here to talk about Medicare promoting interoperability for hospitals. So thank you, Robin.
All right, thank you all. So I always try to recap the morning before I go into my presentation, and it's mainly for me to kind of get my head in the right space before we get started. But so here's my to-do list or whatever. So this morning we talked about managing change, process improvement, waste walks, and types of waste, and that it's okay to ask patients about their mental health, and the fact that the clinic altered their process and added another 20 minutes to do their screenings to buy time into their clinic visit. Now, who wants to do that but hasn't done that? Are we there? I mean, you want to do that, but you haven't done that. So not only did they implement and actually put into practice some of those change processes that Kelly and Jessica talked about this morning, they put it into action and they saw improvements. Then for CEHRT, so Andrew talked about all the services they have. I'm going to tell you right now, I am not paid by them, but you're going to think I am by the time I'm done with this for all the things that I talk about with CEHRT. And then with Coach Colleen, besides everything that was so good about that, the one statement that comes to mind and it applies to so much is when you become aware, you have to be responsible. Man, that's a big deal, right? You have to be responsible. And that we don't celebrate our accomplishments well enough. So I think that's some good takeaways from today. Then one little housekeeping item I want to talk about. So this morning, Brent mentioned the scavenger hunt. So I just want to reiterate that. So some of the slide decks have letters in them that apply to that. Quite a bit of them are already on the pre-recorded sessions. So if you have not watched any of those, please watch those. Jessica has on that second sheet that's stapled to the actual scavenger hunt page. Oh, well, I just really heard myself. She had put the date for the 9th, which is tomorrow. She's extending that to Monday. So first 10 people, I think, is how that's going to go. That emails her with that form attached with the word that it spells out will get a prize. So just make sure your contact information is up to date. So it'll be 5 in person, 5 virtual folks for a total of 10. Okay, so now we're going to get started. So first of all, Medicare Promoting Interoperability Program for Hospitals. Ordinarily, you would see Christina Feathers up here today, and I am not Christina Feathers. So Christina's been on maternity leave. We will see her back in a couple of weeks, and so she and I will be sharing this program again. So our agenda for today is a history of promoting interoperability. I won't spend a lot of time on it, but it will start with where we've been and how we've got here. Our 2022 program requirements, where we are with the calendar year program for the IPPS rule for 23, and then some action items to kind of wrap up the end of the day. So our history of promoting interoperability, we all know that this started back in 2010 with the release of the High Tech Act. We had both Medicare and Medicaid programs. They were incentive-based, and hospitals could participate in both. It was not the same for providers, but hospitals could do both. We started out with stage 1, which is essentially, you know, the adoption or the upgrade of whatever system you had in place. Stage 2 encouraged you to use CEHRT for more particular measures around quality. And now we're into stage 3, which is ultimately to push you towards interoperability. And I know I kind of say that tongue in cheek because we're still not there yet, but we're trying. So with 2018 to present, 2018 is where we saw some significant upgrades to the program. It's where they changed the name from meaningful use to promoting interoperability. They rebranded it. They refreshed the measures that you have to attest to, and they also reconfigured the scoring. So we saw significant change there. We become performance-based. They removed a lot of what we call supportive measures. You know, they took out CPOE and the number of meds and things like that and changed the program. So it had a significant overhaul in 2018. So where we are this year in 2022, course, we're in December. We are in the last 90 days of the reporting period for this year. Most everybody at this point knows where they stand and whether or not they can attest to the Promoting Interoperability program for eligible hospitals or critical access hospitals. So we have any continuous 90-day reporting period. It does not have to start with the calendar. It does not have to start with the first of the month. It can be the middle of the month, just any 90 continuous days. You will have to submit ECQMs, but remember ECQMs are not performance-based. The Promoting Interoperability objectives are, ECQMs are not. So for program year 2022, you can be on the combination of a 2015 edition CEHRT, or you can be on the 2015 edition Cures update, or a combination of the two. You still have to complete your security risk analysis, and new for this year was the Safer Guide measure, and then your minimum threshold to avoid any negative adjustment is at least 60 points. And then our attestation deadline is February 28th. And so a couple years past, they've actually extended that into March, but this year they have left it as February. So just to spend a little more time on the safer guides. So for hospitals, you actually have to assess and review all 9 of the foundational guides associated with the safer guides. MIPS professionals only have to do the high priority practices, so it's a significant difference there in time. We recommend that folks just go ahead and do all 9. It's coming, you might as well just go ahead and do it for everybody. So the safer guides is essentially assessment. This is the link that's active. They're pretty straightforward, but they are somewhat time consuming when you look at all 9 safer guides. When you click on that link, it opens it and you'll see each of them available for you. There's a short 5-minute video that you can share with your teams that you can watch that talks about them. For this program year, you're only required to say yes or no. If you say no, you can still complete the program for that year. You're not penalized if you have not completed those. What we do recommend, however, is if you say yes, make sure it's yes, and that you have that documentation so that you can support it in the event of an audit later. So with stage 3 in 2022, we have 4 objectives. We have electronic prescribing, health information exchange, provider to patient exchange, and public health and your clinical data exchange measures. So not a lot of significant change here. E-prescribing is still performance-based. You have a bonus option for querying your prescription drug monitoring program. If you are able to do that using CEHRT, it doesn't say within CEHRT, it says using certified electronic health record technology, then you're eligible for 10 bonus points. Health information exchange is where we saw a change this year, and this applies to both programs, whether you're applying for hospital promoting interoperability or quality payment program. So it's an either or. It is you either report your sending of electronic information or receiving of your CCDs, or you have the bidirectional exchange. There are folks who do have bidirectional exchange active with CEHRT. There's my first time. I should have added that as a little game. How many times am I going to say that throughout the day? So there are folks who do have a connection with CEHRT that can attest to this. And theoretically, if you do have an active bidirectional exchange, it should be populating in your send and receive measures as well. The significance of having that bidirectional exchange is, one, it's not performance-based. So if you can say yes, then you automatically get 40 points for that particular objective. The other 2 are performance-based. Each one is worth 20 points of that score. And so we all do really well in sending, but we really struggle with the receiving and the reconciling. And so that's where we see a lot of folks having some difficulties. All right, so provider to patient exchange. This particular measure, it's been around for years. It's no surprise to folks. This is where you're making patient information accessible to them through the use of their portal. There is a time limit for hospitals of 36 hours. That's shorter than what it is for providers. There's no exclusion to this measure. So if you do not have a patient portal in place, then you cannot apply or cannot attest to this program. It is worth 40% of your score when you look at it that way. So it does carry a lot of weight in your performance. So keep that in mind. Public health and clinical data exchange. You do have 4 measures that you have to attest to this year. It is 10 points for all 4 of them. So not just each. And then you have the option for the bonus. Just to delve a little bit more into each of them, and I won't spend a lot of time on some that are more familiar, but e-prescribing is that ability to send prescriptions electronically to a pharmacy. This can include your controls or not in this reporting. You can exclude them if you want. There's no requirement that they have to be in this report. And then, of course, your bonus option for querying your prescription drug monitoring program, which is Casper, obviously, for us. There are some exclusions available. So far, we've not had anybody to ever have to use that in the last couple of years anyway. I don't know where to click it. So the health information exchange measure, as I mentioned earlier, this is to expand and encourage the sharing of health information on a broader scale. So we want to be sending CCDs when we transfer patients to a different level of care. A lot of folks have some difficulty with this particular measure because they include in their referrals that hit their denominator any type of referral. And so that's some noise that sometimes shows up. And so if you pull out your referrals to labs and diagnostic imaging, sometimes that measure actually looks a little more achievable and your scores look a lot better. So keep that in mind. And that's for the sending. If you are using HIE1 send, you have to use HIE2 receive and reconcile. And this is where it has to incorporate 3 requirements of allergies, medications, and the problem list. One of the struggles that we see there is sometimes we receive it, but we fail to reconcile it. Or we're learning that as your vendors upgrade, this process and workflow changes. And so that information lands somewhere within the chart and you can't find it. Or it's missing one of those 3 pieces that we mentioned. And then finally, the engagement in a bidirectional exchange through health information exchange. So this is your automatic sending and receiving. You should ideally not have to do anything manually to make this populate, but some of the vendors may have it so that that information, when your vendor goes out and retrieves it and it brings it back, it may be in a special tab within that patient's chart that requires a manual action by some member of your staff. So keep that in mind. There are also no exclusions to this measure as far as not being able to participate in it. So keep that in mind. And then provider to patient exchange. I really feel like this is something that we've been doing for so long that people have a really good grasp on it. But what's important to remember is how is your numerator and your denominator calculating what information is pulling into those. And sometimes we forget, or you have changes in your staff wherever this occurs. If it's at registration, they failed to ask for email addresses. They failed to ask patients if they want access to the portal. And so forth, their numbers start to drop significantly. Again, there's no exclusions for this measure. It does carry the largest portion of the score for this category. So it's highly important and it's almost too easy to meet. So you don't want this one to drop. And then public health and clinical data exchange measures. So we know each year that CMS tends to add to this list. And the latest one for program year 2022 was electronic case reporting. And so if you are connected with KHI, there's number 2. How am I doing, Ann? Where's Andrew? So you should have, by this point, preferably before December the 3rd, signed your addendum to participate with KHI in electronic case reporting. And I'll talk about some changes that's occurred to these measures later, but CMS is cracking down on how long you can stay in option 1 and having that signed addendum. We also, since KHI is able to provide this for us, we cannot use an exclusion with those measures. So you are required to have all 4 addendums in place for 2022. Forget where my thing's supposed to be. And we've done this in the past too. CMS went away from it and now they're bringing it back. But now you'll be reporting your level of engagement with your public health measures. So just as a refresher, active engagement option 1 is that you do have a signed addendum to participate with a registry regarding whichever measure you're attesting to. Option 2 is that you're in testing and validation. So your interface is live with your receiving public health registry and you are sending data and working through any kind of your error messages. And then option 3 is that you're in live production and that you're sending live data up to the registry. And then finally for 2022, when we talk about the CQM reporting requirements, you do have a couple of options now. This will go away, but right now they have give you the option for attestation or electronic submission. If you elect to do attestation, you have to submit all 9 CQMs. And when we say attestation, that's manual data entry at the time. So just keep that in mind. And then it's also for full calendar year. When you're choosing the electronic submission, you have to use safe use of opioids ECQM and then 3 other measures to pick from. You will also be submitting those 4 measures for 3 self-selected quarters. This one does require that it start at a quarter. So January, April, whatever, starting at that time period. And then here's your list of available clinical quality measures that apply for eligible hospitals and critical access hospitals. So safe use of opioids and then 3 from the rest of the stack. Additionally, CMS is going to start publicly reporting your ECQM performance data on Hospital Compare. So while you're not scored on performance, the public's going to see your performance. So keep that in mind. To provide you with the scoring example that we have here, just to give you an idea, when we perform a gap analysis for you, this is kind of what we look like or what we use and what it would look like. So minimum threshold to meet this year is 60 points. It's a yes or no response for your querying the prescription drug monitoring program. It's a yes or no response for bidirectional exchange through the HIE. And then with the public health measures, you would just select yes to those measures as well. So just to kind of give everybody a reminder on what the negative adjustments could be, because we don't like to see those. For eligible hospitals who are paid on the inpatient prospective payment system, there is a potential up to 75% decrease in the market basket adjustment for whatever program year that you're attesting to. So obviously that can change as CMS makes updates to that adjustment every year. Critical access hospitals, their reimbursement to their reasonable costs can actually be a decrease of 100%. We've not solved that, but keep that in mind. These are legally mandated penalties that are written in legislation from the HITECH Act. So these are not going to go away. When we talk about 2023, so what changes are we fixing to see for next year? First of all, here's the link if you want to go out and read the final rule for yourself. If you like the shortened abridged version, there's fact sheets as well. I kind of like the abridged version myself, but I don't have to read the other. So when we talk about changes to the program promoting interoperability objectives, the e-prescribing measure will now becomes 2 measures, 1 objective, 2 measures. So it'll be e-prescribe and then querying of your prescription drug monitoring program. And it's also expanding that to include schedules 2, 3, and 4 drugs. So that is also worth 10 points. So they have adjusted the scoring as well. Additionally, so we have already 2 options for HIE reporting. Now they're adding in TEFCA, and I can say that it's the Trusted Exchange Framework and Common Agreement Measure. So now you'll have 3 options. So you can do send and receive, you can do the bidirectional, or you can report to TEFCA. And then they're adding a new antimicrobial use and resistant surveillance measure and requiring it to be reported under public health. And I will tell you, just in this last probably 10 days, I've had 3 emails about just that antimicrobial use. And what I've learned is folks have been reporting that to NHSN, and they're curious if that's going to count towards this measure. So more to come as we learn more about that. There we go. So for public health, one of the significant changes that we're seeing with here, in addition to adding that extra requirement, so that I actually give you 5, they've made changes to your level of engagement. So first of all, we're going from 3 options to 2. So when you sign an agreement with your public health registry for one of these measures, you now have 1 year to be a engagement or option 1. And option 1 includes now not only your signed addendum, but also your testing and your validation time period. And then your 2nd year, you have to be live during your reporting period. Now, keep in mind, we're still on a 90-day reporting period, so it's giving you some extra time, but CMS reserves the right to extend that reporting period at any point. Public reporting and scoring. So they are instituting public reporting of the Medicare PI program data. So I mentioned 2022, they were releasing ECQMs. Now they're going to start releasing your PI data. They have modified the scoring. eScribe now becomes 20 points because they've added the required PDMP. HIE actually gets reduced from 40 points now of that score to 30. Provider to patient exchange dropped significantly. And so here we were doing so well, and it carried so much of the weight of the program, and now goes down to 25% of that score. So all of your weight goes back up onto HIE and eScribe. Now, public health and clinical data exchange will actually carry some extra as well. They've adjusted that, so it'll carry some more weight than it has in the past. So we talk about electronic quality measures within program year 23. They are adopting 2 new ECQMs into the measure set: severe obstetric complications and cesarean birth. And in 2024, which they've already released, it'll be hospital harm related to opioids and a malnutrition composite score. They are also increasing, because they're not going to take anything away, increasing ECQM reporting from 4 to 6, 3 of which are mandatory. So they're going to tell us which 3 we have to report, and then 3 that you can self-select. That starts in 2024. So you've got all of next year to get prepared for that one. And probably one of the biggest deals that has come out of this is the 2015 edition Cures update functionality. And there's been a lot of questions that came to us and to CMS about this particular piece. So a lot of folks are either still using a combination 2014, 2015 cert, which had to go away. They upgraded to the 2015 cert. And then this year we had the Cures Act released, and it made a lot of changes to the technical workup of these programs. And so for next year, your reporting period has to be certified on a certified Cures update system by the end of your reporting period. And so we've had a lot of questions about what does that do for ECQMs on the MIPS side, because it's a full year. And what does this do for when we report for PI? So our recommendation is first get with your vendor and see where they are on the Cures Act. They may have, in fact, already put this in place and you just don't know about it. If they haven't, start getting a timeline from them, because that ultimately determines what reporting period you're going to use to attest for 2023. So if they don't have it in place, you have a successful reporting period early in the year, you're not essentially going to be able to use it. And then again, we'll be submitting your chapel ID for attestation, which is really not anything new. So your action items going forward. So keep in mind that your reporting year for 2022, your deadline is February 28th, and that you will attest through the hospital quality reporting system. So you need to make sure that you have HARP accounts that are active that allow you to report through QualityNet, and that you have the necessary access. The hardship options for hospitals is a little different. You actually don't submit your hardship application until after the program year is completed. So the hardship application that came open this past couple months ago was only available is for those hospitals who want to claim a hardship for 2021. It's a little backwards. And then payment adjustments, eligible hospitals can see that in 2024 because it's generally 2 years after. Critical access can see that sooner. So your checklist, report your 4 scored objectives for any self-selected 90-day period. Keep in mind your 2015 edition CEHRT and which that you're using, or you can have a combination for 2022. Remember that your CQMs are reported under a QRDA Category 1 file, which is a little different than if you're testing to MIPS. And then you want to go ahead and submit yes for your security risk analysis and your safer guides measures. You'll attest to 2 different measures. They're actually not one like that reads. And then again, if you did not complete the safer guide assessment and you select no, you can still attest this year. So if you're not working with us, here's my one little sales slide. What we provide, we do help you with stage 3. As you pull your reports, we provide you with that gap analysis. We love to set you up on monthly conference calls so that we're on a dedicated time each month set aside to work through the program. And then we obviously during COVID, we're able to do site visits, but we'd like to get those going. Oh, too fast. Hadn't worked all the whole time and then it went too fast. So if you're participating in our scramble scavenger hunt, there's a letter. And then this is our contact information, and I'm willing to take any questions right now. I got my little 5-minute notice a while ago, so I don't know how much I'm down to. 2 minutes. 2 minutes. I think there was some discussion earlier that come over on the Hoover app about quality measures. I really think they applied to the MIPS program. I've asked for some clarification. So if you're still watching us and you're online, I think it had to do about quality measures and if you have a surgeon and things that really don't apply to them. This is where we talk to folks about submitting their data for MIPS as a group under that tax ID because it benefits everybody in there. And that probably doesn't specifically answer that question, but that's just something that we consider because we agree. The other thing they can do is look specifically in MIPS under the specialty set measure sets that's available on the QPP website, and they can find maybe some more measures that's applicable to them.
We have one more question.
All right.
All right. So do we have to query the PDMP through our EMR? Or if we go to Casper through the Kentucky Online Gateway, does that count?
That's a very good question. And I'm going to answer it very delicately and probably broadly. It's probably the best way to say it. The only requirement that CMS has related to the PDMP is that you use CEHRT to access that. It does not say that it's CEHRT through your particular EMR. It just says it's certified electronic technology to pull that information. I think the biggest thing that you need to remember that if you're using something outside of your EHR, you don't have a hot button within it, is can you defend that in an audit? Can you say that you access the Casper prior to prescribing one of the Schedule 2, 3, or 4 drugs? That's the best way I can answer that is do you feel comfortable in how you can support that in an audit?
Yes.
Somebody's trying to give me sign language in the back.
So really it's based on the application you're using and you need to make sure it's certified. And look at your workflows to make sure that you have the appropriate documentation while you're using Casper and the Kentucky Online Gateway to meet that objective.
Yes.
Okay.
Casper itself is a type of registry to some extent, but how you access it is what's in question.
So
my gallery back there want to help?
No, I think the best thing is to look at it individually per hospital
Yes,
location.
you have to.
And to identify, how you're actually accessing Casper
Mhm.
and how are you utilizing the EMR during that approach.
Yes, I have a hospital client in another state that has a third-party system that they actually e-scribe through. It's a certified system for e-scribe. They access their prescription drug monitoring program in that state through that system, can provide an audit. And so we feel very comfortable that they are accessing it through a certified system and can support that. So here's my last pitch for KHI. I didn't mention this. So we have expanded into other states with the hospital support. We are so spoiled when it comes to public health. I'm just going to tell you, we've learned a lot. So shout out to KHI again. How many times is that? Is that like 5, 6? I think that's
Yeah.
$150, I think. But I don't know.
We can't accept money.
I know. All right. And then some resources and things like that. So that's it.
Yes, so thank you. And I think also, thank you, Robin. Yes.